for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity aside from possibly Cash Like Moral Hospital and affiliate outreach programs. If indeed there are any, in fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. This is Dr. Matthew Frank Watto, and without my normal co-host tonight, Stuart and Paul couldn't be here, so I will quickly tell you about the show before I introduce my esteemed mystery guest for tonight, a returning mystery guest. So this is an internal medicine podcast where we do expert interviews to bring you clinical pearls and practice-changing knowledge, and we have quite a wonderful guest tonight. But with me is returning co-host Dr. Cyrus Askin, young Cyrus, I believe, as we were calling you last time. Cyrus, how's the chief residency going at Cashlack South?
Man, well, Cashlack South, what can I say? It is hot, for one thing. But other than the temperature and the occasional mugginess, I have to say that I didn't understand what it meant to herd cats until I started this job. It is truly simultaneously one of the hardest things I've ever done, and it's one of the most rewarding things I've ever done too. So I'm really having a great time, but it's definitely challenging.
To take your mind off that for a little while, why don't you tell the audience about our wonderful guest for tonight and set up the show, because we had a lot of great knowledge coming at our audience in a few seconds here.
Absolutely, I'd love to. So I got really lucky being down at Cashlack South. I was actually introduced to Dr. Barbara Phillips by way of one of her trainees from the past. And so Dr. Barbara Phillips is a recently retired professor of pulmonary critical care and sleep medicine at the University of Kentucky College of Medicine, where she spent her entire professional career. She established and directed the University of Kentucky Sleep Center. Dr. Phillips is a past president of the American College of Chest Physicians and a past chairman of the National Sleep Foundation and the American Board of Sleep Medicine. She served on the boards of the American Lung Association, the American Academy of Sleep Medicine, the Medical Advisory Board of the Federal Motor Carrier Safety Administration, and the advisory board to the National Center on Sleep Disorders Research. She has received a Sleep Academic Award from the National Institutes of Health and an Excellence in Education Award from the American Academy of Sleep Medicine. Wow. Whew. And not to mention that she has mentored numerous students, residents, and faculty alike. And so without further ado, we bring Dr. Phillips on board and are super pumped to discuss sleep apnea with her this evening.
Barbara, the first question that we love to ask our guests is, can you tell the audience a one-liner about yourself and maybe try to include something outside of medicine that gives them an idea of who you are?
Right. Thank you. Well, I'm a very recently retired academician who has practiced sleep medicine full-time for a long time. And honestly, the only thing I miss about my job is teaching. So I'm grateful for this opportunity. Outside of medicine, the honest truth is I prefer most dogs to most people.
That is, I'm not exactly an animal person, but I feel in my experience, dog owners tend to be very nice people. So I'm guessing you're a very nice person.
Absolutely.
So I was kind of curious, since you are recently retired, now that you, in theory, have a little more time on your hands, what are you doing these days? How are you kind of spending that time, and what kind of fun activities do you partake in?
Well, I'm being outside. I'd love to be outside. I don't think very many humans spend enough time outside these days. We've disconnected from that big timepiece in the sky. So I just recently came back from a week at Kentucky Lake at a cabin that I own, where what I did was swim and hike and sit on the dock and drive my little boat around and paddle my little kayak around and have company and swim with dogs, which honestly, can it get any better?
That sounds awesome.
I feel like that's a little better than responding to emails, which is 95% of my job. So
Cyrus has the chief resident doesn't make it into the outdoors quite as much as you are these days.
Yeah.
Before we move on to the main topic, I just want to ask, can you give a book recommendation for the audience, something that you think that you recently enjoyed or something that you think would be meaningful to our listeners?
Well, this isn't a recent reading, but it is a book that changed my thinking about medicine. Because at the time I read it, I was sort of a young faculty member in the ICU doing what I considered to be borderline torture to people as they were dying. And it was horrible. And I read a book called We Die Too Long and Live Too Short. And this is an old book, but it changed at that point in time. This book totally changed my way of thinking, and made me really think about, since death is inevitable, and for some people, even the janitor knows it's coming, maybe we could spare people some torture at the end of their lives.
I have to say I have not heard of that book at all. I'm very
intrigued.
Old
book. Yeah, it's an old book. Yeah.
Cyrus, did you want to ask one more question before we move on?
Yeah, sure. I think I will ask just one more question. So, obviously, Barb, you've had a tremendous career, and it's something we'll certainly be regaling here for our awesome audience. But during that course, during those years of training and practicing, is there one piece of advice that you received along the way that really had a meaningful impact?
Yeah, as an intern, I really struggled. I struggled with never being caught up, never knowing everything I needed to know, always feeling inadequate, and not getting any positive feedback. I didn't hear from much of anybody whether or not I was doing good, bad, indifferently. And more than halfway through the year, I said something to one of my residents about it, and he said, at this point in your life, maybe you ought to be able to recognize and identify your own successes and your own failures and give yourself some of your own feedback. Now, I think I was a little early in my career for me to get that advice, but for all of us, at the end of the day, we need to be our greatest supporter and our most unflinching critic.
I think I'm better at the critic part than the supporting myself part.
Of yourself?
Sure. Yeah.
Of yourself? Yes. But when, you obviously also have to evaluate all kinds of learners and colleagues all the time. And you're probably much better at the supporting than the critic part when it is someone else.
Yes.
I guess my message is we need to celebrate ourselves as well.
I like it. Thank you.
I can't think of a better way to get rolling.
Okay, Cyrus, you want to start us off with a case here?
I think I will. I think I've got a case here. So Dr. Phillips or Barb, the case we've got here is that of Carl Winslow, a familiar name perhaps to those in our audience. So Carl's a 54-year-old African-American male. He's got a history of hypertension, type 2 diabetes mellitus, hyperlipidemia, and obesity with a BMI of 34. He works a high-stress job as a police officer with the Chicago PD, where he spends his days on patrol, working through cases and trying to come up with more constructive ways to deal with his neighbor Steve's shenanigans. He presents to your clinic after a health screening exam revealed excessive daytime sleepiness, difficulty with concentration, recurrent headaches, and fatigue. He can't quite tell you when his symptoms all started, but he does feel like they weren't a problem when he was 5 years younger and 40 pounds lighter. The exam reveals that he's a hypertensive, obese male with an 18-inch neck, and his labs are notable for a hemoglobin of 18.8. And so I don't think it's a shock here to anyone that we're going to be talking about OSA. And so I just kind of, before we really get into it, I just wanted to once again say that I'm thrilled that you're here with us to discuss OSA and kind of remind our audience that OSA is potentially one of the most important medical problems facing our society in 2018. And based upon the National Health Sleep Awareness Project 4 years ago, an estimated 25 million adults suffer from sleep apnea, a number that's definitely greater at this point in time. And I wanted to say that, aside from the symptoms associated with untreated OSA, such as the headaches, the daytime sleepiness, the fatigue, things that Officer Winslow here seems to be complaining of, the disease has also been implicated as a causative or exacerbating factor in type 2 diabetes, hypertension, coronary artery disease, arrhythmias, obesity, depression, and the list really goes on. And so I also wanted to mention that really for those of us that are numbers people, The 2015 American Academy of Sleep Medicine, referred to untreated OSA as a staggering economic burden to the tune of almost $150 billion in the United States. And so, we've started with a case of giving you and our audience especially kind of a reason why we feel this is important. So to kick things off, I'm wondering in particular with Officer Winslow here, what about his history is suggestive of sleep apnea?
All right. Well, so the guy has the metabolic syndrome, right? And we know that well over 80% of people that have this particular tetrad do have obstructive sleep apnea if they're tested. He also, of course, has headaches, morning headaches, probably, and fatigue. And the gradualness of this is also important because, like most things in medicine and nature, sleep apnea is not yes or no, black or white. There are all degrees of severity. In fact, honestly, we are struggling in the sleep field with the cutoff of, what's normal and what's abnormal with regard to sleep disordered breathing. How many times can you stop breathing during a night and still be normal? How low can the oxygen level go without causing damage? So it's there is a gray time when people are not healthy, but they're not quite sleep apneic yet, and we don't exactly know where that is. The one finding here that just nails it, though, because all of the rest of this stuff is pretty common, is the 18-inch neck. A neck circumference, and it needs to be measured, not just like what size collar do you wear, because we all know the men who can't breathe with their collars so tight. They measured neck circumference of over 17 inches in a man or 16 inches in a woman predicts significant sleep apnea about 95% of the time. So our man, of course, has an 18-inch neck. The hemoglobin, the polycythemia that this patient has, suggests something even more severe and different from sleep apnea, perhaps obesity, hypoventilation, or perhaps daytime hypoxemia related to obesity. But this patient is an example of the kind of patient that I personally believe doesn't really need to have a sleep study.
Interesting. That's a really interesting point because I think in primary care, we're very programmed to see, okay, this patient has, they are floridly positive on their stop bang or they're, floridly positive on their Epworth. We need to send them for a sleep study. And that's kind of a very linear thought process, which it sounds like you're maybe not in favor of all the time.
Not in a case like this, when it's really obvious to the casual observer and when your patient is in a safety-sensitive position, as we say, where delay is a problem. I believe that we in the field of sleep medicine are culpable. We have made getting sleep apnea diagnosed and treated take way too long, be way too much hassle, and cost way too much money. If and in your clinical experience, if you had a patient like this and you wrote an order or made a request or sent a consult or whatever you do, evaluate for sleep apnea or get sleep study, how long would it be typically until your patient gets to treatment?
Yeah, it's usually 1 to 3 months in my experience. 1 month would be optimistic. And then they, a lot of the times now, they have the electronic monitoring where if the patient is not compliant to the degree of their liking, they'll take the machine right back.
Correct.
So it's tough.
Correct. And we do, in fact, have a little evidence that patients who have portable or home testing and then are treated with auto-titrating Cpap, in other words, they never spend a night in the sleep laboratory, that those patients actually are better about using their Cpap than others who go through the whole rigmarole. But my point is, this patient is beyond classic for obstructive sleep apnea. And among the things that you mentioned as consequences of obstructive sleep apnea, you did not include what I consider to be one of the very best documented consequences and the thing that makes sleep apnea a public health problem, and that is car crash, moving vehicle crash, because all of a sudden, it's not just his problem, is it?
No, that's a great point, especially, in the case of poor Carl Winslow here. He's a police officer, so I can imagine that that's problematic.
Sure, absolutely. So there's no question that he has sleep apnea. And then, the reason that sleep apnea causes problems is that when you stop breathing during sleep, or any time for that matter, two bad things can happen. One is oxygen falls. And I think, as a pulmonologist, I don't know much, but I do know that air goes in and out and blood goes round and round, and oxygen is good. And low oxygen is bad. And so hypoxemia as a result of stopping breathing during sleep is one of the main consequences of sleep apnea. And it is turning out to be the best predictor of the sequelae of sleep apnea. It turns out, probably, according to work done in Spain, that it's not the apnea plus hypopnea index, whatever that is. The definition changes almost annually. It is the time with the patient having an oxygen saturation below 90%, or the T90, that predicts at least the cardiovascular sequelae. So hypoxemia is one physiologic change that happens. The other that can happen, of course, is sleep fragmentation, right? It's hard to stay asleep when you're suffocating, right? So you fall asleep, stop breathing, wake up, fall asleep, stop breathing, wake up. And this sleep fragmentation probably contributes some to the cognitive dysfunction and obviously to the sleepiness that people with sleep apnea have.
Barbara, I wanted to ask you, you mentioned the T90, which is, I hadn't really, I guess I'm not hip enough to know that term. So I was wondering if you could maybe go through, say I'm a primary care doctor getting a report from a sleep study, what should I pay attention to? Like if you're pressed for time, what numbers what will we see on there, and what should we pay attention to? What's just noise?
Okay, so the metric that people have hung their hats on for years is the apnea plus hypopnea index, otherwise known as the AHI. And that is the number of times that a person has a complete apnea, defined as stopping breathing for 10 seconds or longer, or a hypopnea, which currently has at least 4 different definitions.
Okay.
But a hypopnea is some reduction in airflow, plus or minus an arousal from sleep, plus or minus some degree of oxygen desaturation. And frankly, it is the variability in the hypopnea definition, and therefore in how the apnea plus hypopnea index is calculated, that has left us in kind of a mess of knowing what is sleep apnea and how bad is too bad. But at any rate, people will look at the apnea plus hypopnea index, and if you are a naive clinician, which I am sure you're not, or an insurance company administrator, you think that an apnea plus hypopnea index of less than 5 is normal. You think that an AHI between 5 and 15 shows mild sleep apnea. And according to a recent ATS paper, we probably shouldn't even try to treat mild sleep apnea unless the patient is sleepy. You think that an AHI between 15 and 30, and this is the number of times they stop breathing or struggle to breathe during sleep per hour, right? So 15 to 30 times an hour they stop breathing or they have a hypopnea. You think that's moderate. And then you think an AHI of over 30 is severe. And there's some correlation between how high the AHI is and outcome for sure. But the variations in how the AHI is defined and calculated has led us to an epidemiologic nightmare. Other things to look at then, besides the AHI, a simplistic and kind of variable measure, are the degree and duration of oxygen saturation, right? Because hypoxemia is really the prime mover and shaker of cardiovascular disease. So how do we quantify that? Well, one way is what is called the ODI, the oxygen desaturation index. That would be the number of times the oxygen saturation falls, typically by 4% per hour of sleep. And some investigators, including in the Sleep Heart Health Study in the United States and the Spanish sleep cohort in, guess what, Spain, have used the ODI as their primary metric of sleep disordered breathing. They use it instead of or interchangeably with the AHI. But it is more reproducible because there's not a lot of variability. Like, did this line fall by 30% or not? You know what I mean? So the ODI is probably a more reproducible and more predictive metric, actually, than is the AHI, which is used by naive clinicians and insurance company administrators. But then finally, work from the Spanish cohort suggests that the number of minutes during a night of sleep that the patient spends with a saturation below 90% is most predictive of all. It is the thing that correlates best with the risk of congestive heart failure. It is the thing that is most predictive of incident cancer. And then, of course, cardiovascular disease and all the sequelae as well. So I would suggest if you get a sleep study report, look at the AHI, because if it's not above 5, you're not going to get the Cpap paid for. And if it's not above 15, the patient's unlikely to use Cpap anyway. But more importantly, in trying to figure out how bad it really is, look at the oxygen saturation. If a patient has an AHI of 20, but his oxygen saturation never goes below 90%, he's in much better shape than somebody with an AHI of 10 who spends 30 minutes with an oxygen saturation below 90%.
That's outstanding.
Thank you so much. So
very high yield.
So
my pleasure.
With the home sleep apnea testing, I guess this is called HSAT in the literature, versus the polysomnography, the PSG study. What different information do you get there, and where do you stand on which one we should be using more of?
I think the home sleep study should be the gold standard. I think that we should use the home sleep study for a bunch of reasons, including the primary metric there is oximetry, so you can get your T90 and your ODI, but also people tend to sleep better in their own beds. Also, because you could probably get a home sleep study done on somebody this week instead of waiting a month for it, and also because it is much less expensive. But there are at least 4 good randomized controlled trials showing that outcomes between in-laboratory sleep studies and home sleep studies are pretty much the same, except for 2 things. With home sleep studies, people tend to adhere to Cpap better. Nobody knows why, but that's kind of important. But also with home sleep studies, you do have a greater chance of data loss and having to repeat the study. So I really think we should use home studies as the standard thing and only do an in-lab study if we have a good reason to do so.
And we can link to some of those. There was a couple of them in 2017, the home versus the PSG, and so we'll put some links in the show notes to those. And I wonder if it's just, when I was talking to patients about sleep studies more often than I am these days, they would always say like, "Oh, I didn't sleep in that lab. I don't believe that test." So maybe if they're home and they do a home sleep study and it's positive, maybe they're more likely to be invested and believe the results. Maybe that's part of it.
I think that's true. And I think when patients tell you that they didn't sleep as well in that laboratory, they probably are also telling you the truth. But at least in the laboratory, you are measuring sleep, which you cannot do with a home sleep study generally. So at least you could tell whether they slept in the laboratory or not. At least you can, investigate that claim. Okay.
Cyrus, where do you want to take it from here? I know we have limited time with Barbara, and I really want to make sure we get to all our big burning questions.
Yeah.
Sure. Why don't I ask? What are the consequences of sleep apnea, and how do these patients kind of present in the clinic with problems that maybe require additional intervention aside from just treating their sleep apnea?
Right. So it is pretty rare for somebody just to have sleep apnea and nothing else, right? But there is one message that I would like to get across clearly in this broadcast, and that is that you don't have to be heavy to have sleep apnea. People do have sleep apnea for all kinds of reasons, including they are hypothyroid. They have a receding chin, or even an anomaly like Down syndrome or Treacher-Collins, where the pharynx is misshapen and therefore narrowed. There is clearly a genetic predisposition to sleep apnea. And we know, for example, that people from China are at increased risk for sleep apnea, although they, as you clearly know, they're not as likely to be obese. Postmenopausal women are likely to have sleep apnea sort of independent of their body mass index, probably because, frankly and sadly, everything is sagging, and that includes the palate. Little kids with big tonsils have sleep apnea. So you don't have to be heavy to have sleep apnea, but a majority of people who have sleep apnea are heavy. So a majority of people who present with sleep apnea also have diabetes and hypertension and dyslipidemia, and all of those consequences that go along with that. Sort of like our patient here.
Right.
It's interesting that our patient had recurrent headaches, and it is clear that untreated sleep apnea is a risk for morning headache in particular, and that appears to be related to hypoxemia, which if you've ever been at altitude and had that headache, I imagine it's something like that, because it is the same pathophysiology. Mm-hmm. We know that for some, but not all patients, sleepiness is the most important symptom. It's the thing that gets them in, sleepiness. And it is also the thing that keeps them using Cpap. If you have a patient who's taking 3 antihypertensives, so he's referred by his nephrologist, who knows that there's an association between difficult to treat blood pressure and sleep apnea, but this patient isn't sleepy, he's not very likely to adhere to Cpap, even when you tell him, well, we might be able to get you off 1 or 2 of these blood pressure medicines. But if you have a patient who is not able to stay awake at her workstation because she is so sleepy, and she uses Cpap, and it's like, all of a sudden she's awake, she is going to use Cpap. Sleepiness is an important symptom because in and of itself, it predicts death, it predicts cardiovascular disease, and it predicts Cpap adherence. And there's this big debate in the literature about whether we should even try to treat people with sleep apnea who are not sleepy, because first of all, they may have a slightly reduced risk of cardiovascular consequences. Yes, I'm going to say this again. Cardiovascular consequences are most strongly linked to degree and duration of hypoxemia, but sleepiness also tends to be associated with increased risk of cardiovascular consequences. And why is this? I don't know, it has to do with leptin or something, little things that I can't see and therefore don't understand.
Barbara, I wanted to break in and ask you, because this is a question we got repeatedly on Facebook and Twitter. People wanted to know, how much can we tell patients that good Cpap treatment will lower their blood pressure, and does it have a mortality benefit, either cardiovascular mortality or all-cause mortality?
Okay, that's a really good question. So in observational studies, people who use Cpap had much reduction in blood pressure compared with people who did not use Cpap. In randomized controlled trials, intention to treat analysis did not show a benefit in blood pressure with Cpap compared to those who were randomized to no Cpap. But in those same randomized control trials, and there was a big one out of Spain, when they did a secondary analysis and they looked at the people who used Cpap 4 hours a night compared with those who did not use Cpap at least 4 hours a night, there was a blood pressure reduction advantage. So my take on this is CPAP can lower blood pressure and reduce the risk of incident hypertension. But here's the kicker. You got to use it.
Right.
Again, in studies of mortality, observational studies have suggested that people who use CPAP live longer than people who don't, given that everybody has sleep apnea. But there are, as you guys well know, characteristics of people who don't adhere to medications and medical treatment that also, predict poorly on their adherence. Randomized controlled trials showing a benefit of CPAP in mortality have not happened yet.
I'm sure it's hard to prove because it's hard to get people to use the CPAP. And then, so if you're looking at a population, there might be, like you're saying, the population of adherent patients who are probably making other lifestyle changes too. Maybe those people
Correct.
have a mortality benefit, and that's why you see it in the observational studies.
Correct. That is true. But in the blood pressure studies, clearly there was a cut between those who used CPAP and those who did not in terms of hypertension risk. So I think you are on reasonably safe ground to tell them that if you use CPAP at least 4 hours a night, there is a good chance that your blood pressure will fall, will be better controlled. You'll need fewer medicines. And of course, we know that hypertension is a risk for all of the other things we worry about with sleep apnea, including things like stroke and heart disease and so forth.
So we're going to have a lot of questions for you, like kind of rapid fire questions towards the end.
Okay.
But the next question I wanted to ask you about this, because I think this is always so helpful to our audience. When you're counseling a patient that's going to newly start CPAP, what sort of things do you say to them to try to get buy-in, and how do you coach them through maybe the first visit or two while they're using it?
Good. Those are great questions. So the first thing, people talk a lot about motivational interviewing, and frankly, I think generalists are better at this than specialists. But you got to go back to what it was that got the patient to got him to have a sleep study to begin with. Did he have the sleep study because of sleepiness? In which case, you can tell him with assurance, right? The one thing that CPAP does is that it relieves sleepiness in sleepy people, right? You can't promise them it'll make them live longer. You might be able to promise them it'll lower their blood pressure if they use it, but you can promise them that if they're sleepy and they use CPAP, their sleepiness will improve. But then you got to go back to why they came to see you. If it's because their wife won't sleep with them anymore, you can tell them that the gentle white noise that a CPAP machine makes is a heck of a lot quieter than their chainsaw. Plus, at least in one randomized controlled trial, CPAP did improve erectile dysfunction. If they came because of morning headaches, you can say observational studies have shown that CPAP improved morning headaches in people for whom it was the presenting complaint. So, you got to go back to why did you come? What's in this for you? And address that specifically with them. Because if somebody doesn't even have hypertension and you go on and on about how it's going to help that, obviously that's kind of a waste of everybody's time.
Yeah, you're missing the boat on that one.
Yeah.
What about the mask fitting, different masks? Have you had better success with any specific type, or maybe auto CPAP, APAP versus just the continuous?
Wow. Sure. Those are great issues. So the right mask for the patient is the one that the patient will wear. But there are 3 basic kinds of masks. By far and away, the most commonly used and prescribed CPAP mask is a nasal mask, and it just fits over the nose. The 2 alternatives to that are a full face mask. It goes over the nose and the mouth. The idea being that if the patient's a mouth breather, the air can go in through the mouth as well as through the nose. And then the third kind is so-called nasal pillows that look just like big fat oxygen cannulae that get a pretty good seal. So they deliver pressure through the nares, but there's nothing that goes over the whole nose. I always tell patients, go to cpap.com or Google CPAP masks and look around, look and see what's available. There's not a whole lot of evidence to say that one mask is better than the other, although there is some emerging data. Well, there's two things that are emerging in the data. The first is that nasal masks and oral masks probably require different pressures, so that if somebody is titrated in the laboratory with a nasal mask, but then ends up being prescribed an oral mask, the pressure that they were titrated to in the laboratory might not be right for them with a full face mask. The other is that probably, or at least there's a signal in the literature that full face masks, by that I mean the nose and the mouth masks, might be associated with higher pressure needs and also worsen compliance. And I'm starting to believe that data. So I would recommend for starters that if the patient has a real preference, well, woohoo, you've got an engaged patient, right? What more could you want?
Sure.
Order that sucker, whatever it is. But if they don't, then nasal mask. In terms of auto-titrating versus fixed pressure CPAP, auto-titrating CPAP allows you to bypass the sleep center altogether, right? You can do a home study at home and then order auto-titrating CPAP. What could be better? Cheaper, right? Adjust to the patient whatever they need. They drink a little bit too much, it can up the pressure. They lose some weight, then it can lower the pressure. So that's the benefit of auto-titrating CPAP. And now there's not really a cost differential between auto-titrating and fixed pressure. Having said that, there is starting to be a little bit of a signal in the literature that diabetes control might not be as good with auto-titrating CPAP as with fixed titrated CPAP. And that might be because with auto-titrating CPAP, you set the pressure, and I would recommend if you order auto-titrating CPAP, and we do it every day, that you set the pressure auto-titrating 8 centimeters of water to 16 centimeters of water. Why do I say that? Because 90% of people end up on 10 centimeters of water plus or minus 2. And hardly anybody is effectively treated at a CPAP pressure of less than 8. And hardly anybody needs more than 16 centimeters of water CPAP unless they're really, really heavy or they have some huge craniofacial abnormality. And so what will happen is the patient puts the CPAP mask on and it's at 8 centimeters of water, and the pressure ramps up until vibration stops in the back of the pharynx. So the pressure ramps up to whatever that takes. And let's say that's 13. The patient falls asleep and everything is good. But then the patient gets on his back in REM sleep, and all of a sudden there's more inspiratory airflow resistance, and the pressure has to ramp up again. That is an event that may be associated with a surge in blood pressure, a little bit of sympathetic outflow, perhaps some change in epinephrine, and that may be why we are starting to see this signal about diabetic control improved with fixed CPAP, but not with auto-titrating CPAP. It's interesting, isn't it? Having said that, I'm still a big fan of bypassing the sleep lab whenever you can. Home study, auto CPAP, see the patient back. That auto-titrating CPAP, which you have wisely set to 8 to 16, will give you a download. And that download will tell you where that patient, at what pressure that patient spends 90% of her time. She spends 90% of her time at a CPAP pressure of 12.3. Put her on a fixed pressure of 13.
Wow. I like it.
It's very, very, very powerful tool, and I could see that being very effective to help us with our patients.
Well, you know why you don't hear more about that?
I would have just thought it's because CPAP is how we were taught. I don't know.
We need to get these people into the sleep labs, titration studies. That's why, right?
I guess I guess it earns some money, huh?
Well, we've made an animal that needs to be fed.
Exactly.
I like how you're retired now, so you could say these things.
You can ask anybody. I've been saying these things for 20 years.
You are awesome. I love that.
So I actually had a question. It's kind of like this has been a recurring theme on our Twitter, on our Facebook, and it's kind of like, other than CPAP, APAP, what have you, medications, oral adjuncts, surgeries, all those other things, even like online, you can find a billion different sleep apnea.
Radio frequency ablation of the pharynx or whatever.
So can you dispel at least some of the rumors? Other than CPAP, other than APAP, what can we turn our patients onto if they're interested, and what should we just tell them to leave for the snake oil salesman?
Okay, to just answer that succinctly, oral appliances and surgery. In other words, oral appliances made by a dentist, or what is called mandibular advancement devices, have clearly been shown in the peer-reviewed literature, even including randomized controlled trials, to lower blood pressure and improve sleepiness. They are not snake oil. It takes a while to get one. A study suggested that it could be 6 months between the time that you send the patient to the dentist, he gets an appointment with the dentist, gets the device. They have to custom make them, and they're adjustable now. And there's something like 30 different brands of them that are FDA approved, each separately. But it can take 6 months for them to get the thing delivered and adjusted. But they clearly are appropriate, reasonable treatment for people with moderate or mild sleep apnea, or people that are just not going to use CPAP. And we send people to the dentist every day. Surgery, I don't know what I can really say here. I don't want to get sued or anything, but let me just say that in my opinion, any kind of upper airway surgical procedure is still experimenting on your patient. Now, there are some surgeries that are effective for sleep apnea: bariatric, tracheostomy. These surgeries work for sleep apnea.
Yeah, I can imagine that giving someone a trach probably does the trick, and it probably is not the preferred intervention for most of our patients.
Well, you don't have to imagine. We have data that definitely demonstrates it does the trick.
Sure.
And
you bypass. Yeah.
And Cyrus, this was recently pointed out to me by a pulmonologist at Cashlack, a fine pulmonologist at Cashlack that I work with. I've probably seen this more times than I realize, but some of these patients, very large neck size, they come in the hospital, they leave the hospital with a trach and a peg. That trach should not be reversed because it's cured their sleep apnea, and it's going to make some of their other medical problems easy to treat. I'm not sure, Barbara, if you feel that same way, but that was pointed out to me. I was like, oh, I never really thought about it that way before.
Boy, do I feel that way. I feel very strongly that way. And as a pulmonologist working in the ICU, I certainly experienced those patients that everybody knew had sleep apnea who would not use CPAP. And they wind up in the ICU, and they're not going to use CPAP, and they get extubated, and then and they do well, for a night or two, but then they get intubated again. If somebody with sleep apnea, either known or strongly suspected, and as I say, I really don't think that we need to do a sleep study on somebody who weighs 350 pounds, has, hypertension, difficult to treat, never mind. But somebody that's strongly suspected of sleep apnea or known to have sleep apnea who hasn't used CPAP on, the outside, trach them. It's a favor to everybody, especially the patient.
Yeah. All right, Cyrus, I think we should go to the lightning round and kind of go through some more of these questions.
Sure.
What about modafinil? This is I've been asked about this before. I had a patient at Cashlack who swore by it. What do you think about that?
Gosh, I wish I had some. I wish I could take it. I wish I could get my insurance to pay for modafinil to compensate for the fact that I'm 66 and not as smart as I was, or maybe I didn't get enough sleep last night, or and it's only $800 a month or
Oh my God.
whatever. Yeah. So perhaps you get some idea of the flavor of my response. It does have an FDA approval for the treatment of residual sleepiness in people with treated sleep apnea, with adequately treated sleep apnea, and those people are out there. And the basis for this is that untreated sleep apnea that's longstanding can damage the alerting center in the brain, resulting in sleepiness that isn't going to get better on CPAP. But I will confess that I have not been eager to prescribe modafinil. I think it's one of our latest lifestyle drugs. And I will say this as well. The biggest cup of bold Starbucks coffee has the same effect on psychomotor vigilance as does 200 milligrams of modafinil. It's a little bit cheaper, though.
What about the converse question, the Z drugs? Let's say a patient's like, Doc, I can't sleep with the CPAP on. If you give me some Zolpidem, maybe then I'll be able to tolerate it.
You know what? There's no study that's ever shown that any hypnotic, any Z drug improves CPAP adherence in people with insomnia. People without insomnia, where it's not even their complaint, there's a very slight move of the needle of CPAP use per night, but not people with insomnia. And I got to tell you, the risks of chronic, and we would be talking chronic here since CPAP use is chronic, the risks of chronic use of hypnotics far, far, far outweigh any proven benefit.
I think that's like exceptional data and a great way, I think, to approach that question when it comes up. Along a similar vein, one of my colleagues had asked about a 2018, I guess it was a commentary on dronabinol for obstructive sleep apnea. Can you comment at all on that?
Not intelligently.
Sure. Okay. It looks like it was, no, that's fine. It looks like it was a New England Journal, like a commentary on it potentially being efficacious for difficult to sleep apnea.
So we're getting into the final couple questions here, and then we'll get some take-home points because I want to be respectful. I know this is late, and we thank you so much for recording with us. We had a question. About people with driver's license issues related to sleep apnea. I imagine you might have gotten referrals for this sort of thing. Is there any way around this? Like if someone has sleep apnea, like if they're a commercial driver, they have a CDL. Have you ever dealt with that before?
All the time. Okay, so these are two very different categories of people, right? Commercial drivers versus us amateur drivers with sleep apnea. With commercial drivers, there's no way around it. If you don't want to deal with them, send them to a sleep center or a certified CDL medical examiner. For us amateur drivers, and I would recommend that you review this ATS statement from 2016, I believe it was. You should advise and warn and document that you advised and warned, but you really don't have to report these people, nor probably should you. I mean, an important public health principle is to not stigmatize a common, deadly treatable condition. And
Sure.
Frankly, I think that's what depriving somebody of their driver's license if they have sleep apnea, I think that's stigma.
Well, we've gotten a lot of great stuff. Cyrus, did you have any last questions before we get take-home points?
I think maybe to lead into the take-home points, Barb, given us some great points on sleep apnea and kind of highlighted why it's important for primary care docs. But kind of, in your opinion, what do you feel is the future of sleep medicine?
Boy, is that a great question. Well, sleep apnea is more prevalent than asthma. And a long time ago, we understood that asthma is way too prevalent and way too deadly to be managed by specialists. I'm embarrassed and ashamed that sleep specialists tend to still cling to the notion that only they can diagnose and manage sleep apnea. because there are not enough of us to do it. And at the end of the day, who suffers is the patient, but not just the patients, of course, the people on the road and in the shotgun seat with them, and also their family, and and all the rest of it. I think the future of sleep medicine is that sleep apnea, like any prevalent deadly condition, which has a known and effective treatment, is going to have to be managed more and more by generalists. For one thing, the treatment of sleep apnea improves or can improve all the metrics that matter to generalists, like blood pressure and diabetes control.
Any other major take-home points you'd like to leave our audience with before we let you go?
Just that this is sleep apnea is different, for example, than diabetes, in that untreated sleep apnea does not just kill the person with it. It kills anybody on the road with them.
Well, thank you. I'm sure we could ask you a lot more questions. We had more from social media, but I want to let you go, and I want to thank you so much for all your time. I will let you know when this is going to come out, which will be in a couple weeks' time. And really can't thank you enough.
Thank you. Sorry about all the dog noises.
No, it's great. No, we sure appreciate it.
Traditionally we've been a cat show, so I'm really glad that we've been able to have a dog make an appearance on air, because my normal co-hosts have cats meowing in the background all the time.
Oh, I see. So diversification. This is excellent.
Yeah.
Yeah. Well, I'm honored to have been part of it. And guys, thank you for reaching out. I appreciate this opportunity very much.
Oh yeah, no. I'm so happy that you were able to find time for us, and I think that this is going to make a meaningful impact for our audience. So thank you so much. This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Get show notes at thecurbsiders.com/podcast and sign up for our mailing list at curbsiders.com/knowledgefood to get our weekly show notes directly to your inbox.
And we're committed to providing you with high-value, practice-changing knowledge. So send us your feedback. You can subscribe, rate, and review the show on iTunes, or you can reach out to the Curbsiders at gmail.com, or on Facebook, Instagram, and on Twitter at the Curbsiders. And I'd like to thank our social media team, Hannah R. Abrams on Twitter, Beth Garbitelli on Instagram, and Chris the Chiu Man Chiu on Facebook. Until next time, I've been Dr. Matthew Frank Watto.
Wait, where's Stuart?
That's you, Cyrus.
I guess it's just me, and I've been Dr. Cyrus Askin. Thank you so much for listening.